with our rhythms, a lot with your ACLS. So this is not a very long. So we're going to talk about the CPR situation, using their equipment, and stressors. So the main thing to know is sudden cardiac death. So this sudden unexpected death caused by the loss of heart function. Largest cause of natural death in the United States. Different thing. Oh, this is still there. Okay. So myocardial failure, acute MI, structural abnormalities, defib. Okay, so different things can cause sudden cardiac death. Yeah. Okay. So this, and I gave you a little thing there on your lecture notes. Cardiac and non-cardiac. So cardiac thing, cardiac drug toxicity, inflammatory, coronary heart disease. Non-cardiac could be a PE, autonomic dysfunction, electrical shock, electrolyte acid-base imbalances. So you have different reasons that they can go into sudden cardiac death. Oops, forgot that. Reperfusion, cardiomyopathy, valve disorders, aneurysms, and over here we have cerebral hemorrhage, and choking could be a non-cardiac. So what is a cardiac emergency? So anything that causes severe decrease in cardiac output. This leads to decreased circulation to the vital organs, which can lead to death. Okay, so they may present with severe hypertension, chest pain, dysrhythmia, or be in cardiopulmonary arrest. So we need to recognize it immediately to take care of it before it gets to the death part. Do not be afraid to do compressions. Remember, you cannot make them any deader. Okay. Again, we went over signs and symptoms. They, I think I give you like through K. So restless, anxious. If your patient tells you, I don't feel right, I'm going home today, you be ready, especially if they're a full code. 9 times out of 10, they know it, and that's going to happen. Okay? So you be ready, even though everything may look good, vitals are fine, labs, they know something's wrong. Okay, has any of you ever had that happen to you yet? So just be ready with your patient tells you that. They don't feel right good, they're having arrhythmias, may have skin color change, hypoxia, could be having pain or fatigue. Their level of consciousness could change. And we also could have a respiratory arrest. So respiratory arrest is cessation of breathing. So they still have their pulse. They're not really in any problems with the heart. So mainly we're probably just going to tube them and assist with that ventilation. So we may suction, they may have their advanced airway, so the respiratory arrest is a little bit different. They may just need assistance with that ventilation. And a respiratory arrest in ACLS means respirations are completely absent or inadequate to maintain oxygenation, but a pulse is present. And we don't ever want to hyperventilate because that can lead to increased intrathoracic pressure, diminished cardiac output, increased gastric inflation. They talk about that in your book, I think. So what's our goal of resuscitation? We want to reestablish effective circulation and respiration, preserve function in those vital organs, right? We don't want kidneys shutting down. We don't want this or that. Where's my phone in case Lisa has it? That's our goals. Priorities for successful resuscitation. Defib within 2 minutes. You know, we want to get ready, get it going. CPR going while we're waiting and after we shock, right? Hands off for only how long?
10 seconds.
Less than 10 or less. CPR, get that secure airway and the oxygen. We're going to give them epi, maybe pacemaker. Again, it depends on their rhythm. Code status. So full code. We all know what that is. You do everything you can. DNRCC is comfort care. You don't see many of those on the med-surg floors. Mostly the 2 West, I know how Health will have a lot of hospice patients or a lot of DNR. What was your status, Jessica, yesterday in the ICU on those patients that did die then? Was they DNRCCAs?
Yeah, both of them were.
Okay, which is very unusual in the ICUs to have those, you know. So once the family decided nothing, then they let them go.
They were just changed that morning.
Was they? Okay.
Yeah.
So DNRCCA, we're still keeping them comfortable, maybe still giving them meds, doing this or that. We're just not going to be proactive like a full code, okay? It used to be when we had the DNRCCA papers, they could check, okay, I want intubated, but I don't want meds, or I want compressions, but no meds, or I want meds, but no compression, you know. So it's very iffy situation.
So I saw on the ICU that it was DNRCC with limitations. So would that fall under the DNRCCA?
Yes, yeah.
Okay.
Different places may categorize theirs different, but that would be a limitation, yeah. Because it's just the CC is just mainly comfort care. Yes, we still give them morphine and give them oxygen, but we're not going to be aggressive. So that's a good point, yeah. We went over roles when we did some of the ACL's videos. So again, you will be team leader. You will be a med nurse. You will be bagging. You will be doing compressions. You will be monitoring those rhythms. What that means is you would tell your team leader when a rhythm changes. And if you're on the monitor, you will be doing the pacer or you will be doing the shocking, okay? Our new ones that you haven't got to use yet, we did use on CPR, but not the laptop that goes with it. It will shock and everything on there. And you will be the recorder, okay? So you will have your time on all those. We're going to be mainly grading. You're not grading per se, but passing you when you're your team leader, okay? So that is the main, that's why you have to know those rhythms. When we change them on there, you need to know what your rhythm is. You need to say, as soon as that rhythm changes, pulse check, okay? Any rhythm change, pulse check, okay? Because it could be what? A PEA, right? Even though the rhythm's showing, we will tell the ones checking the pulse to say yes or no, there is a pulse, okay?
And then do we need to know what medications to push as we go?
Again, you're going to have your cards. That's in your books. You know, don't forget the day you do your test and your mega code to bring your books and your cards and any notes. So you're going to use your cards during this. So you don't have to memorize those, okay? Now, we may, if we throw up an AFib, we may expect you to tell us, you know, what you're going to give. Or if we throw up an SVT, that's not going to be on your cards per se. But you should know those anyway, okay?
Okay, thank you.
Okay. Again, how do we know we're going to verify it's a true arrest? Remember way back at my first lab or whatever. What do you do when this happens on the monitor? Make sure it's really happening. Don't just take the monitor's word for it. Go check, assess your patient. Going to do CPR, crash carts. Code team's going to come. You're going to have your monitor on. Team leader's going to take charge. IVs, intubation drugs, ABGs, documentation. Backboard, defibrillator. A lot of you will forget to pull out that backboard on the crash cart and put under your patient. But there is backboards on all the crash carts. Next time you're at clinical, look at the crash cart. You cannot open it. Don't dare try to open it. But you can look around it and on top. So they should have a defibrillator on there. Inside should be IV equipment, airways, oxygen, meds, Foley, suction equipment, goggles, gloves. When you're here next week, go ahead and open the drawers and look through our crash carts. Now, they're not exactly like the ones at the hospital, but we've got most of this stuff in there. Common drugs, and again, you do know these already. So amiodarone, epi, lidocaine, you'll see that ever so often still in codes. They don't give it a lot. That's why I've never really pushed you guys to know that. And it is, I think, on your algorithm cards. Adenosine, atropine, and epi. So those are ones, that's why we went over all those with each rhythm, because you're going to use them in your codes. Ways to give your meds. Your most normal way is going to be IV, right? Peripheral line. Do you have to have an order, Nikki, if you walk in and your patient's coding? Do you need an order to put another IV in?
No.
No, you want to always have a good IV. So if somebody comes to help you, say, hey, throw an IV in the AC, because that's usually where they're going to get it quickest and get a bigger line in there in case what we give them. So you do not need another order to get an IV, of course. If they can't get an IV, they may go intraosseous into the bone. Very few times where they use the tube, but that has been done. And then they may have a central line already, which would be nice. I have seen central lines put in femoral during a code. It's very, very tricky, but they do it. So never give PO, of course, during a code. So okay, and these are just some of your algorithms that you have in your cards and in your book. So there's your Brady, and then your Tacky, and then your one for the VTAC, VFib, or asystole PEA. So these are the cards that you will be looking at and telling us. And if you've not really looked at them good, it's going to tell you over here what to do. It's going to tell you see, there's lidocaine on there. It's going to tell you the doses. So you would tell your med nurse, okay, give epi 1 milligram. Okay, give lidocaine. You want to say that. So take a peek at your cards before next Thursday. So you bring your cards next Thursday. You don't need your books, but bring your cards for the practice, okay? Okay, so you had your assignment. Most of you got it done. And like I said, I did delay it a little bit today. So the therapeutic hypothermia. So that's what we want to try to use. It does help them neurologically after a code, right? It was a very good article. And I actually found that when I was flying to, was it Florida or Washington one? In the airplane book, the books on the airplane. I thought, oh my gosh, this is a great article. And it was. It's a little older, but it is good. How many has seen this done in ERs yet?
We use it in my CVICU.
Okay, good. Anybody else? They don't always use it, but I think it does help with outcome for sure. Have you seen that, Michelle? Good outcome using it?
Yeah, it usually does help.
Yes, good. So we want to maybe try that. So you can tell us when, you're saying, and even the one algorithm showed that on there, therapeutic hypothermia, so you can tell us, oh, we're going to do this to this patient, get them up to ICU or whatever then. So we're going to make sure the blood sugar is controlled and neurological care. 2 responses we want to see with resuscitation. First, hopefully, is maximal response. We're going to get the patient to come out. Eventually, he's going to be breathing on his own. All his EKG, heart and lung sounds are good. Identify the cause of the arrest to prevent another. Is it something he's doing or something inside his heart that needs fixed so he doesn't have this again? So that's our maximal response. Single or multi-sister failure, so the patient's transferred to ICU. Respiratory is not good. The cardiovascular is not good. He may arrest again. Some of them you just cannot get them back to where we want them to be. And again, it depends age. It depends comorbidities. So we do what we can, but it's not always possible. Okay, they taught in ACLS videos. I think you may have questions on your waveform capnography. Okay, the assessment tool used doing CPR. Remember, we went over that, I think, like the first video. So you will see us, are we going to, normal range 35 to 45. Are we going to be very strict on you watching that during the code? We may have you look at it, but that's not mainly what we're looking for when you our team leader, so. But just know it's gonna show up on your monitors, so. And you know your H's and T's, right? You see those again and again. Okay, I got a little bit of video about,